So Musab, you can start.
Assalamu alaikum and good evening, everyone. It is my pleasure to be the moderator for today's session. As you know, the SSBMT has been having our weekly webinar series since the beginning of the pandemic as a way to keep up to date with the latest literature and also connect with colleagues and world experts on different hematologic topics. Today, we're pleased and honored to have Professor Gallup Evans, who's a consultant clinical oncologist for almost 2 decades and clinical director at Velander Cancer Center in Cardiff, the UK. She's a lymphoma and pediatric radiotherapy specialist, and she's also the regional lead for cutaneous and Hodgkin's lymphoma. She also has a PhD in cancer immunology. She was the lead for the UK radiotherapy group, as well as the European Pediatric Hodgkin's Lymphoma Trial Group, and chaired the NCRI Hodgkin Lymphoma Clinical Trial Group for 5 years, from 2011 until 2016. Today, we're pleased to have her to share with us her expertise on how we manage T-cell lymphomas, the cutaneous T-cell lymphoma. As you know, this is a particularly challenging disease, low cure, if any, cure rates with frequent morbidity from the disease. So we're very pleased to have her today, and we also would like to thank our sponsor for the talk, Kiowa, for their support. So Professor Evans, please, you can begin.
Good evening. Can you see my screen?
Yes, and we can hear you.
Lovely. Assalamu alaikum. Thank you for having me. Inshallah, the connection will work. So it's my pleasure and privilege. And as I said, I'm very impressed that you're doing this on your sort of weekend evening before your busy week starts. So thank you. And thank you for the very kind introduction, very generous introduction. And I think, you know, my perspective from this talk is definitely not as an expert, but these are really challenging lymphomas. And I hope I give you some flavor of our approach to it in the UK. And in a way, as someone who works in a regional cancer centre in Wales, you know, our numbers of CTCL patients are small. So we're always struggling to get that expertise. And, you know, in some ways, so I think that does bring a different perspective. My declarations of interest. And so my talk is going to cover, they're not really common types, but you know, these are the types of CTCL that we see, mycosis fungoides, Sézary, and the CD30 positive lymphoproliferative disorders. I'll talk a little bit about making the diagnosis and staging, and you know, emphasizing the point that this is a multi-compartment disease, skin, nodes, blood, and viscera. Talk a little bit about prognostic factors and really, you know, the treatment principles and multidisciplinary management underlying the management of these rare conditions, and you know, all things that are very familiar to you as hemato-oncologists. It's the same principles, and again, you know, perhaps peculiar to these conditions is the real unmet need for patients and their families. So there was a 2018 update of the WHO EORTC classification published in Blood, covering all the primary cutaneous lymphomas, and again emphasizing that these are probably the 3 most common ones that we see: mycosis fungoides, primary cutaneous anaplastic large cell lymphoma, both, you know, as a population of patients perhaps doing reasonably well, but Sézary syndrome much less common, but you know, has a universally poor outlook. I was interested to try and find out what your practice might be, what you see. And, you know, this was an interesting paper I saw Just Giving, you know, it's a retrospective single center review, just showing the sort of broad spectrum of patients that you might see, predominantly patch plaque disease and a bit of erythroderma. I think the interesting thing in your region was that, you know, the presentation tended actually to be in younger patients, but, you know, sometimes younger patients do very well and don't need as many intensive treatments. But that was a very helpful review. But making the diagnosis, and that can be particularly challenging. You know, these patients often have a long sort of prodromal period before they have the diagnosis, and they present in many varied ways. So, to illustrate this, I'll be talking about one of my patients, and perhaps he's not particularly so common, in the sense he was a bit younger, he's 48, and he had about a 3-year history of what was being treated as eczema by his GP. Sometimes for patients, it's almost 10 or 20 years of having, chronic eczema. And actually, he had a very poor response to topical treatments. And perhaps he's also unusual because his first biopsy did confirm mycosis fungoides. Sometimes it does take multiple biopsies. But we'll be following his progress as we go through. So mycosis fungoides is the commonest type that we see because, in some ways, although the incidence is low, early stage patients can do very well. So the prevalence, particularly, that it's a dermatologist who perhaps keep the early stage patients managed with topical treatments. So they're in the dermatology clinics and may never see an oncologist. They present with patch and plaque disease, may progress to tumors or erythroderma, and there can be blood involvement for mycosis fungoides as well. Or patients can present de novo with any one of those stages, for example, straight with tumors or erythroderma. Characteristically, the biopsy shows sort of homing of the T lymphocytes around the epidermis, forming these microabscesses, and it's usually in excess of CD4 lymphocytes rather than CD8. There are different variants, follicular tropic, which tends to see the malignant T cells clustered around a hair follicle. And one of the tips from the pathologists is that they recommend that we try and target biopsies to hair-bearing skin. Sometimes patients have alopecia, and sometimes if you catch a hair follicle in the biopsy specimen, you can see the sort of grouping and clustering around that hair follicle, which gives the diagnosis. Pagetoid reticulosis is a rarer variant where it's usually a solitary lesion on a distant or acral site, and granulomatous slack skin just cause skin atrophy and you get skin folds. That's quite rare, but this is a patient of mine who had that characteristic alopecia, so loss of hair. That's an important clinical feature to ask patients about, particularly around eyebrows. Sézary syndrome is fairly characteristic, and it is often older patients, and they present with quite dramatic erythroderma. They get ectropion with drooping of their lower eyelids. They usually have often palpable lymphadenopathy, and they have peripheral blood involvement. So it is the leukemic variant of CTCL with a high Sézary cell count. And an abnormal CD4 population that is picked up on flow. The clinical behavior is usually very aggressive, and although the literature says median survival 3 years, I think in practice, with older patients, I find it sort of 12 to 18 months for patients who are not always fit for systemic treatment or have very short responses. So this was a second case that I looked after, a 71-year-old woman who presented with a relatively short history of erythroderma, severe pruritus, and you can see the excoriation because of the scratching. I mean, unusually, she had absolutely no symptomatic or clinical response to either topical or systemic steroids and didn't respond to methotrexate. She had a detectable T-cell clone in the skin, lymph node, and blood, and a rapidly rising lymphocyte count, and had the diagnosis of Sézary syndrome. So again, peeling, erythroderma, and severe pruritus. Investigations for patients, again, fairly similar to systemic lymphomas, and to some extent, when a patient presents with cutaneous lymphoma, clearly, we're always excluding the fact that this might be secondary skin involvement of a systemic lymphoma. But otherwise, it is a whole skin assessment and biopsies. And I guess, I say biopsies because sometimes patients do require multiple biopsies over a period of time. It really can sometimes take 2 or 3 years because biopsies are often non-specific, and the pathologists remind us that there has to be very good clinico-pathological correlations. We have to look at the patient, because it isn't always a biopsy that will give us the answer. It's the same for nodal examination. Often patients have dermatopathic nodes, and again, if you pick up a T-cell clone in the skin, at least you can be looking for it in the blood, looking for it in the lymph node. We obviously do immunophenotyping flow cytometry on those compartments, and again, the standard bloods, including a virology screen. For early stage patients, we don't routinely do CT staging unless they've got palpable nodes. And again, we might only do a PET CT if there's high-grade transformation. And it's very rare to do a bone marrow biopsy. It's rarely clinically indicated, doesn't particularly help us with a diagnosis. We tend to, concentrate on looking in the peripheral blood. And, it's something that's gone out of practice, really. So slightly unusually, it's not the Ann Arbor staging, but it's TNMB, emphasizing the multiple compartments. And perhaps, the unusual thing is that stage is not necessarily directly related to prognosis. So you can see it's T depending on whether it's less than 10% of the skin surface or more extensive disease, nodal involvement, whether it's sort of macroscopic or microscopic nodal involvement, and it's quite unusual to get visceral involvement, except at very late stage transformation and blood involvement, according to absolute counts. But you can see that 1B is, 1A is less than 10% of the skin surface, having patches or plaques. 1B is at skin only and more extensive with no nodal involvement, but actually can sometimes be more problematic than someone with stage 2A disease who might have limited T1 disease, even if they've got nodal involvement, and even if there's a T-cell clone that we pick up in the blood. Then you've obviously got erythroderma, and the Sézary patients come in with B2 involvement, so they are stage 4A from the start. And at any point, a patient can demonstrate large cell transformation. So again, just to make the point that prognosis isn't a direct sort of stage related. So 1A and 1B can do a bit worse in survival outcomes, and 1B can do a bit worse than 2A. But you can see that, some patients can really, have a very, very normal life expectancy, but, the stage 4 patients with that blood involvement certainly drop off very quickly initially, and their life expectancy is much shorter. Just a brief mention of primary cutaneous ALCL. It's part of the spectrum of CD30 positive lymphoproliferative disorders, and it's a very characteristic clinical presentation. A large proportion of CD30 negative, so that gives us therapeutic options. And these tumors can grow very quickly, can become very large and necrotic, and can regress or ulcerate, although in this condition that tends to take a bit longer compared to lymphomatoid papulosis, when that happens over a short number of weeks. So for these patients, they generally do need treatment, and both these patients actually had radiotherapy to start with. So that was a radiotherapy response, and that was a radiotherapy response because it is a solitary lesion. But clearly there is a differential. So we have sort of general guidelines for management, that includes diagnostic, staging, and treatment of primary cutaneous lymphomas in the UK. And I was looking at these and I was thinking, really, it's almost very similar to our approach, perhaps for follicular lymphomas. Say, if someone presents with very early stage, and if there is a solitary lesion, then in general we may be able to treat them with curative intent with radiotherapy, but otherwise for most patients it's incurable, at the time of diagnosis. But early stage patients may still have a very good life expectancy, maybe 20 years plus. And, trying to explain this to patients is key, really, because there is very little information for patients out there. They don't have the support groups and, the knowledge base, even from their treating teams and oncology and hematology teams compared to our systemic lymphoma patients. So trying to get them to understand that this really is, a chronic, incurable condition, and there is no treatment that improves overall survival. So treatment is purely directed at symptom control and improving quality of life. And certainly for a CTCL patient, that's a lot more challenging than for a follicular lymphoma patient. So in general, we haven't got a long list of treatments. So, there is a real unmet need for active treatments. We tend to cycle through them all. Patients will generally go through all the active things that we have at some point. And it's kind of trying to pick something that is most acceptable to the patient, the lowest anticipated toxicity that suits the patient at that particular time. On the whole, patients can respond, but responses are short duration. And this point, we are starting to consider more patients. There's more data emerging about reduced intensity allogeneic stem cell transplant using what's called the Stanford protocol conditioning. It's a relatively light conditioning regimen, but again, a bit like follicular lymphoma, say you're almost trying to identify patients at diagnosis who might be transplant fit. So those are the younger, fitter patients, because perhaps your treatment choices might determine what you or rather, if they are transplant suitable, that might determine what choices you start off with. So these are all things that we're very familiar with in systemic lymphoma management. So again, this kind of looks busy and it looks exciting and as if it's got lots of options. And in fact, it's behind the lines that there's probably not a lot to it, but patients come in at different stages, and first line options are generally, these patients all have skin involvement usually that needs treating because they have skin symptoms. So topical therapy, light, ultraviolet UVB, PUVA, things like that are all first line options that in general are managed under dermatology. And they may well also have systemic prednisolone, say, and oral methotrexate as first-line systemic treatment. But there'll be a handful of patients who do very well on those treatments, but most patients will end up, progressing, becoming more symptomatic, short duration of response, and then move very quickly to a second-line option. And, the things that we have are things like bexarotene, which is a retinoid, and interferon, but, slow onset of action. Bexarotene is particularly challenging. Patients get hyperlipidemia, so end up on a lot of statins, fenofibrate. Managing central hypothyroidism is really challenging. And even on maximal therapy, they can still have fasting triglycerides of 10 to 12, which does give them a significant risk of pancreatitis and cardiac complications. So a lot of our patients have cardiac, risk factors anyway, so this can be challenging. Interferon is a subcut injection given, the patient has to really give it themselves 3 times weekly. Again, can cause depression, fatigue, flu-like symptoms, challenging. Brentuximab for CD30 positive patients, is an option, but not many patients are necessarily CD30 positive. And I'll be talking a little bit more about mogamulizumab, which is a really exciting new, option because it's a humanized monoclonal antibody, which is very well tolerated. But as I said, really, you need to sort of cycle through all of these and consider whether you have got a patient who might be suitable for a transplant or eligible for a transplant at, say, second or third remission. Clinical trials, definitely, but there aren't many at the moment. Campath isn't particularly used much in the UK. It's fallen out of favor. These patients have a very high risk of sepsis because of their skin risk. Conventional chemotherapy, it's gemcitabine, or, we don't usually use CHOP. It's not normally recommended to use multi-agent chemotherapy. They respond for 1 or 2 cycles and then progress. So Calyx, liposomal doxorubicin, is sometimes used in chemotherapy. ECP, photopheresis, radiotherapy. So you can see, it's you end up trying everything. And it's similar for Sézary. The harder thing with Sézary, obviously, they're probably using, you want a reasonably fast-acting systemic agent from the start. So things like bexarotene and interferon don't really add much. But for older patients, ECP is helpful for managing the pruritus. But otherwise, they do generally need chemotherapy, but again, have very short responses. But mogamulizumab now is licensed in this indication as second-line treatment. And again, Sézary, perhaps less often CD30 positive. And again, I certainly haven't taken a Sézary patient to transplant as yet. So my 48-year-old man, and he was, relevant because, he was young and fit. He had skin-directed therapies, including radiotherapy to lesions. He had, the usual systemic therapies at our disposal, methotrexate, interferon, bexarotene. He'd have brief responses and then progress. Just a point about palliative radiotherapy, it can be very helpful for lesions. It's a relatively low, so this is low dose radiotherapy. A bit higher than the 4 Gray and 2 fractions we give for palliative radiotherapy for like follicular marginal zone lymphomas, so not quite the boom boom regime, but still low dose because you are sometimes retreating and treating overlapping sites. So and this was a patient 6 weeks after treatment of that. And again, this patient, had very hyperkeratotic lesions and responded well. So a very useful treatment. And you will have heard of total skin electron beam therapy. So that is when we treat the whole skin surface, from head to toe with radiation. So electrons are produced by an electron shield, and this is a linear accelerator. So this is a standard linear accelerator that's used for conventional radiotherapy or total body irradiation. And an electron shield scatters the gamma rays and produces electrons. And the benefit of electrons is that they have very superficial penetration. So this shows that within a couple of centimeters of penetration from the skin surface, the dose is dropping off. So you can very nicely treat skin surface and minimize the dose to organs at risk any deeper. So this is, these slides come from Stephen Morris, the oncologist in Guy's St. Thomas's in London. So essentially, it's a bit like TBI when we rotate the gantry, and the patient having TBI for a transplant is at the end of the room to get the divergent beam. But for this, you have a patient standing with skin exposed in different positions, trying to get as many of the surfaces exposed as possible. So quite a tough treatment, takes quite a long time to deliver that. The patient has to be fit to be standing up and maintaining those positions, and you need to boost the scalp and soles because clearly they're shielded. But it is a very effective treatment, and actually low dose, relatively low dose can be palliative treatment and repeated as well. So the physicist just demonstrating, this is the physicist at Guy St. Thomas, and again, just showing a boost to the soles of the feet, but it's not an easy treatment. So my young patient started to transform to tumors, and they were CD30 positive, large cell transformation on biopsy. He was having radiotherapy, which helped, but because of the CD30 positivity, brentuximab was an option for him. And there is good data in a randomized controlled trial that took patients with CTCL and randomized them between brentuximab and investigator choice of methotrexate or bexarotene. Patients going into the study had to have over 10% CD30 positive on central review. It was a bit controversial whether methotrexate and bexarotene are real comparators to, what's essentially systemic chemotherapy, but certainly there was improved response rate for patients treated with brentuximab compared to the investigator choice, and improved symptom relief. So this is an option. It's approved as second-line systemic therapy for CD30 positive MF or Sézary or primary cutaneous anaplastic large cell lymphoma. And this is a patient I treated who progressed on gemcitabine. And so brentuximab a second line, she had, a rapid response. And obviously we'll have seen, responses to brentuximab in systemic lymphoma. But this was, a useful response that was a bridge to transplant. So my patient did respond well to brentuximab, and he also proceeded to Aricalo. He had a matched sibling, but sadly, he did relapse within his skin within 3 months. We did a biopsy to make sure it wasn't graft versus host disease, but it was disease relapse. He had a bit more palliative chemotherapy and radiotherapy, but sadly died, caught COVID and died at the end of last year. So the new kid on the block, so it's great to have, another active treatment. So mogamulizumab is an antibody, a monoclonal, humanized antibody against CCR4, and this seems to be important for T-cell homing to the skin. So it's highly expressed on cutaneous lymphoma cells, and it's expressed on Th2 and Tregs, and in cutaneous T-cell lymphoma, it's highly expressed on the clonal T cells, and is, was found to be a good target for therapy, and hence the development of mogamulizumab, and it induces antibody-dependent cellular cytotoxicity, and causes depletion of these malignant T cells in the affected compartment. So this was also tested in a randomized control trial for patients failing at least one systemic line of treatment, and there were 186 patients in each arm. In this study, the comparator was vorinostat, an HDAC inhibitor, an oral HDAC inhibitor. And again, it's been a little bit controversial in the UK because this is not routinely available in the UK, but in this study, there was a significant improvement in median progression-free survival for patients treated with MOGA compared to vorinostat. And in fact, there was crossover. Patients who didn't respond to vorinostat or had toxicity were allowed to be treated with MOGA. And overall response rates, again, favorable, reasonable, median time to response, and response duration, again, better compared to vorinostat. So this is FDA EMA approved for relapsed refractory MF and Sézary after at least one line of systemic therapy. And I gather it's also does have that licensing in your region as well. A little bit more data again, so for both MF and Sézary, looking at the overall response rates and time to next treatment by blood classification. And in a way, we know perhaps from treating follicular lymphoma that it isn't just about response rate or median duration, it's actually time to next treatment, which is a meaningful endpoint for both a clinician and a patient. It's even if you relapse, if you don't have to start treatment for a reasonable duration, that is a good outcome. So for investigator-assessed overall response rate, there was a significant difference between the two arms for, MOGA versus vorinostat, which was statistically significant. And what was particularly remarkable was the responses in the blood compartment. So that was a real sort of, headline sort of grabbing result, because these are the patients who actually do very badly. But there was a significant benefit and significant activity for B2 patients. And again, same when you're looking at time to next treatment, significant difference from intention to treat for MOGA and vorinostat, which was significant, but again, marked for patients, particularly with B2 involvement. So certainly for MFSS patients with that blood compartment involvement, there is a very active treatment. So the second patient I mentioned, my 71-year-old lady with Sézary syndrome, she had no response to steroids and methotrexate. She had extracorporeal photopheresis, ECP, which helped her pruritus significantly, but her lymphocyte count was rising. And at the time we had access on the kind of company access scheme. So we started her on MOGA. And I have to say it was very impressive because, as you can see, this was her lymphocyte count. And on this axis, that's 50, 40, 30. So a rising lymphocyte count, started MOGA, cycle 1, day 1, and a rapid fall in her white blood count and lymphocyte count. Symptomatic improvement in skin, but she was also having ECP, but a dramatic improvement in blood compartment. And amazingly, no adverse effects. I mean, in the study, it's mainly fatigue, diarrhea, and infusion reactions, but very few grade 3 or 4 toxicities. So, it's just nice to see real world data in my own practice for what was being reported in the trial. But coming back to managing the patients, and these treatments all very well. What we need is a treatment that we can continue, because patients live with their skin tumors and pruritus. It's treatments are generally short in duration. So, when I have a CTCL patient waiting for me in clinic, they sit there with their hoodie up and they don't want to wait out in the main outpatient clinic with other patients. It's cosmetically very, very disfiguring. and long-term control of symptoms and improved quality of life is absolutely key. So we really do need new therapies, and this is a population. So even though it's a rare, they are rare cancers, rare lymphomas. We really do need new treatments that can target all the compartments and give a durable treatment response and are well tolerated. So, in summary, CTCL is very challenging to manage. I mean, we have, we rely on super regional multidisciplinary teams to help us make the diagnosis, advise on, because as I said, making the diagnosis in the first place can be very difficult. So it is that clinico-pathological correlation and, trying to analyze what a flow result means and, whether we can, PCR is often polyclonal. It's hard to demonstrate clonality. The treatments are all quite specialized. They're often novel agents or trials or total skin electron beam therapy, ECP. Transplant needs to be considered. And as I said, we desperately need new treatments, but these are some of the things being tested. So you can see that our patients and their families, it's hard enough when they're in hospital to manage dressings and, let alone when they're at home and that, they're sort of managing bleeding wounds and, fungating ulcers and soaking dressings. It's really difficult. So our patients desperately need better and new treatments. So that was all I was going to say. So thank you to our patients, and their families, and thank you thank you for inviting me and to talk tonight. I hope I've shared with you my lack of expertise and the fact that, as I said, I continue to struggle. Unfortunately, this, I did submit my slides a while ago. This is when Wales was still doing quite well in the Euros, but sadly, we will have to be supporting England now. The journey ended there.
Yes, great. Thank you so much, Professor. Really nice talk. And you highlighted elegantly how challenging it can be to manage those patients, and you gave it some good insights. Just a reminder for our audience, we have the Q&A session or section, so you can submit your questions to me in text, and I'll put them through the professor. And in the meantime, I can probably start with some questions of my own. Now, I find personally, I probably get 1 or 2 new patients with cutaneous T-cell lymphoma per year, and as you mentioned, with their life expectancy, they tend to accumulate, so they become more challenging with time. And one of the challenges that I personally face is the fact that we do not yet have a combined clinic with the dermatologist. So I do find that the care is probably a little bit fragmented, where I see the patient today, they get to see the dermatologist later. And although we can communicate directly, I think having a combined clinic where the patient is seen by both, and probably even plastic surgery in some cases, wound care, etc., that can really uplift the care that these patients can get. So I was curious what your...
I agree. I mean, it is, we also struggle because, I mean, you really do need your interested dermatologist, don't you? And that is key. And I think, the joint, so rather than the patient having to shuttle between clinics, everyone's standing around. I mean, what I find very useful is that I also learn a lot, about sort of skin. And I often see sometimes the early stage patients rather than just seeing them when they run into problems. But even when a patient is established on systemic therapy, they have constant skincare needs, which we can't address. So, your dermatologist absolutely needs to stay involved. I mean, often the patients are sometimes attending, dermatology daycare and having the dermatology nurses apply the emollients and the dressings. But I agree, putting heads together and ideally at an MDT, sometimes having, the pathologist also, or at least clinical photos to the pathologist when they're reporting these biopsies is absolutely critical. Because that's a really challenging thing. Is you really need to tell them what the clinical picture is, what the clinical suspicion is, because it's not something you can just report and diagnose down a microscope.
Thank you. Yes, I fully agree. One thing I find that many hematologists probably don't know very well is the skin-directed therapies, particularly when it comes to light therapy, so PUVA, or some total skin radiation. So when and probably we tend to think of them as one treatment. Now, would you say, when would you consider one over the other? Is it purely just related to the side effect profile of the treatment, or is there something particular?
Yeah, I mean, a good question. And, you know, to start with, the UVB and PUVA are very simple, straightforward patients that I guess, you know, I mean, it is a light sensitive, you know, it's actually very responsive. So early stage patients, some of them can be managed for a long time on those therapies and get very good responses, you know, and also using topical treatments. I mean, some patients don't tolerate UVB, they do get burning, and obviously the cumulative dose has to be watched because they then develop a risk of skin cancers. But that's the most simple treatment that dermatology will oversee. So that will always be the starting point. I mean, I think a patient who's failing to respond to that, but has extensive skin only disease. I mean, you could, you know, it does, if you've got low level lymph node or blood involvement in MFs, total skin electron beam therapy is still useful because, again, it's a symptomatic treatment for skin control. I would normally do a test dose, and, you know, if a patient responds well to radiotherapy for a lesion, you know, without excess toxicity, then they would be a good candidate. I mean, they do have to be quite fit, you know, and but we've started using lower dose regimes. It used to be, you know, 5 weeks, and now come down using, you know, 2 weeks and sometimes even 1 week, just to kind of get some palliation, accepting that you might need to retreat, but it's much better tolerated. And actually, the Stanford conditioning protocol for the Rick Allows also uses total skin electron beam therapy, but at a higher dose, because skin control is absolutely critical for those patients, and you really need that with radiation.
Now, when it comes to using extracorporeal photophoresis, I have tried this for a couple of patients, and to say the least, I found it very challenging, mainly because of line management. So the incidence of line infections was very high. I also had one patient with the line coming off easily because of probably skin elasticity issues and whatnot. So how do you, personally, I wasn't, I didn't find it a successful attempt anyway, and ended up being aborted before we could judge.
Yeah, I mean, I think, you know, I think that is a definite issue, and I've had it with a couple of patients as well. I mean, sometimes even access is difficult, isn't it? And, you know, I suppose it's one of those things to be managed. I mean, I think when it is about patient selection, and for some patients, you know, when the logistic problems can be overcome, and they're patients who respond, but, you know, getting that sort of all those things aligned is not always easy. Sometimes patients are too unwell, as you say, you know, infections, and, you know, the response is not particularly durable. So, you know, it's an option. You know, and that said, because I'm not a hematologist, I don't have the experience for GVHD. I don't know whether you have fewer problems in those patients, but I agree, CTCL patients, it's not always you know, that easy to do, but for certain patients, when it works well.
Oh, certainly for chronic GVHD, this is where we've used ECP the most, and I mean, it's not without its challenges, but certainly it's been, for us, much easier to use rather than for cutaneous. Just started another lady about 2 weeks ago, ECP for Sézary syndrome, and within a few days of line insertion, she came with bacteremia and removed the line.
Yeah, and, you know, it's, I mean, and in some ways, those are the problems they have with systemic treatments as well, don't they? They're in and out of hospital, and then their skin, you know, they get excoriation and skin weeping, and, you know, and that's why, for me, you know, the life expectancy of those patients is worse than is often reported. They, you know, they do very badly. They're very difficult to treat. Yes. I agree.
Now, could you walk us through how you would sequence the systemic therapies? I know when you look at a trial, for example, just Hansa with methotrexate versus brentuximab, obviously here in CD30 expressing. It's true that one is clearly better than the other. That being said, you do need both agents. So recognizing that probably a patient need methotrexate, would you still use methotrexate and sequence, and once they fail, then you go on to brentuximab, or is brentuximab? back to
I mean, theoretically, brentuximab is after one, is second systemic, second line. And usually the dermatologists will start oral methotrexate first because it's what they, it's sort of their bread and butter for the psoriasis patients, and they use it for other conditions. So usually they send me patients who are failing methotrexate, or there's a reason why they can't have methotrexate. So, but I would try that first because it's so much simpler, very well tolerated, and I think if a patient is well established on between 10 to 30 milligrams, weekly, then you use something to the best of its ability. You use it for as long as it's working. You don't give up on something until it really has run out. So I would always start with methotrexate first because it's simple. I mean, brentuximab, it is an IV, it is 3 weekly. They do get peripheral neuropathy, and they do respond, but I find, that again, it's hard to get durable responses beyond 5 or 6 cycles. It starts, people start relapsing, getting more symptomatic before the next cycle again. So as you say, you end up cycling through all of them, and you pick them according to, almost I use the more chemotherapy agents when I want a faster response or a patient is fitter. And I would use single agent gemcitabine, although you have to watch for a skin flare. I've tried Calyx and liposomal doxorubicin, but again, hand-foot syndrome is a problem. I mean, bexarotene, I think if a patient is you don't need an urgent induction regime to get rapid control. Bexarotene is attractive, and but I really do have challenges with that I ignore the hypertriglyceridemia for as long as I can if a patient's responding and tries to sort of persuade me to, but I bottle out at about, when it starts getting to double figures, and, the blood is lipemic when it's collected, it's a bit frightening. And, there's so much concomitant medication with bexarotene, but some patients really do well on it. And, I've had patients on it for a couple of years. So if you can find someone who doesn't have the metabolic, malfunctioning, it's a good option. Interferon, I've struggled, and there was a point when interferon wasn't available here, but I think it is now. But I have to say, the professor of dermatology I worked with came from Geneva, where they used a lot of interferon, so he was very pro it. But I have to say, in my experience, it never really hit the sort of patient acceptance box, and not great responses, and yeah, fatigue and flu-like symptoms were a problem.
I see. I have one practical question. For patients that have anaplastic cutaneous lymphoma, do you do surveillance imaging every now and again, to look for potential transformation to systemic disease? And if you do find the occasional node here and there, do you go after chasing it with biopsies, or do you?
No, well, I have to say that, I can't think of any lymphomas we do any surveillance imaging for at all. So not at all. It would be symptomatic presentation or someone presenting with palpable nodes. Yeah.
And my last question, actually, can you share with us more experience, your own personal experience on the use of mogamulizumab? Because it's something that we have not used yet. It is now registered in Saudi Arabia, but at least in my institution, we have not used it yet. And if you could.
Yeah, so we've been talking, I mean, my personal practice is small, but I've recommended it, again, to other colleagues in the region. And we are collating UK data to try and get it published, again, because we were writing to kind of support, the application for routine reimbursement funding. So, and as part of that appeal, we were using patients as part of that sort of process to give their stories. I mean, the effect on the blood compartment is dramatic, and patients who, young and old patients, it's so well tolerated. I mean, it's a bit like rituximab, but, there is almost imperceptible toxicity from treatment. The question is if they respond or not. And patients who respond really well and for a durable period, and it is so easy to give, and very acceptable to patients. And as I said, some patients, I mean, when the COVID pandemic hit, we did stop some of these routine patients or prolong the treatment interval to 6 or 8 weeks to someone who was on treatment, trying not to stop it. But at that point, we were having to completely change, all our treatments and ways of working. And some patients did start to relapse once the interval, but did respond when restarted. So, I've just shared the experience with, UK colleagues in London and Manchester and Birmingham, which are the biggest sites. And it is a very active drug, particularly for Sézary patients. And, those are the ones who are very hard to treat, but also, MF patients with blood involvement. So, it's, I guess until you've got, maybe that's your Sézary, is that someone, your Sézary patient who's failed ECP, would they be a good candidate for that?
Probably, probably.
Yeah.
Yes.
I mean,
yes.
It's a really good, so we are, really hoping that we get that through.
Yeah, and like you said, I mean, we could use all the agents that we could have, and
yes,
good safety profile and symptom control.
Because for brentuximab, they do have to be CD30 positive, and peripheral neuropathy, is a.
Do you always use that 10% cutoff, or would you use it in someone?
I think, I mean, in the trial, I mean, certainly that stated in the trial, but in practice, we probably just look for CD30 positivity. Again, we're usually desperate to try things in patients who need treatments.
Yes, I agree. Thank you. Professor Ahmed, do you have any comments or questions?
Thank you. Well, thank you for such a nice talk and discussion. This is definitely covering this difficult topic and rare disease, I would say, that's being encountered by the hematologist, and requires, as you said, the combined approach between dermatology and hematologists and oncologists. Have you do you consider bortezomib as part of the options, especially for Sézary syndrome? Have you
no, I have to say it's never. No, I've never considered that or seen any data. I have to say it's not something that's come up on my radar. For is that something that's been tried, or I'm not aware of any.
Well, we had actually one case that was treated with bortezomib with a good response of a Sézary syndrome, and the patient eventually died, but it took her a while, I guess, and being managed, I guess, for probably a year. Whether that's effective, and I don't remember how we came up with this option, but I thought if there is any data that we're not aware of.
No, well, I'll have to look. I'm not aware of it being used in T-cell lymphomas, but it'd be interesting to see, because as you say, what you want is a treatment that you can give on an ongoing basis. Something that has to be given, say, for 6 cycles, like conventional chemotherapy, is no good for these patients, because they you ideally want an ongoing treatment that's well tolerated, and that's where MOGA, I think, has a benefit.
And in such a chronic disease, I mean, it's like you need to have multiple options, and you will run out of the available options, and you start to explore new alternatives sometimes.
Yes.
And sometimes this is how we build experience with these diseases.
I agree, and I do think sometimes that first patient consultation with the patient and their family is very challenging, because they come full of hope and optimism that you can help, and it's a difficult discussion, and as managing patients' expectations, and that sort of pruritus and the burning and things they get, those are really challenging symptoms to help. It's you really feel for them, so it is difficult.
True.
Yes.
I think there is.
I don't see any
no more questions.
No more questions, and I think I've reflected on all the issues in my mind, so I have no further questions. If not, I think we can close. Again, it's been a pleasure, Professor Evans, really the enlightening discussion. Thank you very much for joining us this evening. And we hope to see you again in the future.
Inshallah, thank you. Well, I feel I shared my inexpertise with you, but we're all in this together when we're looking after these patients. It is challenging and difficult, but thank you very much.
It's been a pleasure. Thank you so much again.
Bye-bye.
Have a good evening. Bye-bye.
Thank you.